When most of us hear the words lactic acid, we picture a heavy sprint or a tough set of squats, the familiar burning sensation of a muscle pushed to its limit. Inside the intensive care unit, this same molecule signals a systemic emergency. Here, an elevated lactate level is a primary indicator that the body's internal environment is becoming life-threateningly unstable. This chart shows the specific clinical threshold for danger. The white line tracking blood pH drops below a 7.35 baseline, while the red line representing serum lactate simultaneously crosses above 4 millimoles per liter. This shift into lactic acidosis means the bloodstream has become dangerously acidic. This acidity impairs the heart muscle and destabilizes major organs, leading to multiple organ dysfunction if the trend isn't reversed. To understand why this chemical shift is so lethal, we have to trace the reaction backward, from the patient's overall blood chemistry down to a failure in cellular power generation. A spike in lactate marks the point where the body's basic ability to generate and use energy begins to fail. Under healthy conditions, your cells rely on aerobic metabolism, a high-efficiency process that requires a steady, continuous supply of oxygen from the bloodstream. Here, oxygen and glucose enter the mitochondrion, producing high volumes of ATP energy. But during shock, oxygen delivery drops, halting normal production. To survive, the cell bypasses the dormant mitochondrion, converting glucose into a flood of lactate to keep minimal energy flowing. Clinicians refer to this specific oxygen-starved pathway as type A lactic acidosis. There is also type B, which occurs even when oxygen is available. In these cases, toxins, specific medications, or liver disease physically break the mitochondria or prevent the liver from clearing the lactate away. While this emergency shift allows short-term survival, the resulting flood of lactate into the bloodstream creates a new systemic crisis. The true threat to the patient's stability is the surge of highly acidic hydrogen ions, or protons, that flood the bloodstream alongside every molecule of lactate. Doctors use the anion gap scale, balancing positive sodium against negative chloride and bicarbonate, leaving a gap for natural unmeasured particles. Excess lactate fills this space, widening the gap. But low albumin in critically ill patients shrinks this gap, masking the acidosis completely. To find the hidden acid, doctors must use a corrected anion gap formula, manually adjusting the math to account for the missing protein. Without this correction, a medical team may miss the early signs of a crashing patient, losing the window for intervention before organs fail. As the blood becomes increasingly acidic, the heart muscle loses its ability to contract effectively. The acidic environment also prevents life-saving medications, like adrenaline, from binding to cell receptors, making standard resuscitation efforts less effective. Because the acidosis is fueled by a lack of oxygen, it creates a cycle difficult to break without addressing the physical cause of the shock. While infusing an alkaline buffer like sodium bicarbonate might seem like a direct fix for acid, it often fails to improve survival. Bicarbonate doesn't restore the flow of oxygen to the cells, and it can actually lead to an increase in carbon dioxide levels within the tissues, further complicating the body's attempt to regulate its internal pH. To stop the production of acid, the medical team must restore oxygen delivery to the dying cells at the start of the chain. This involves aggressive IV fluid resuscitation and the use of vasopressors, medications that constrict the blood vessels to force blood pressure back up. These steps are designed to physically push oxygenated blood into the oxygen-starved tissues. Resolving the lethal chemistry of lactic acidosis depends on a mechanical solution, restoring the physical flow of blood and oxygen to every cell.